What is the importance of reticulocyte count? Somebody is having anemia and his reticulocyte count is more than 2%. What is your inference? It simply means iron is there, folate is there, everything is there, and the RBCs are normally produced, but after being produced, when they are released into circulation, they are being destroyed. There is a hemolysis. Hence bone marrow is trying to compensate that hemolysis by overproducing reticulocyte count. Hence a retic count more than 2% implies significant hemolysis is the ongoing process. But if retic count is less than 2% in an anemic person, what does it mean? It means either iron or folate or nutrients required for production of RBC are missing, or bone marrow is suffering some aplastic anemia, hence in spite of anemia there is no retic count production. So that means erythropoiesis got affected is implied by a low retic count at the time when there is anemia. One more important thing to learn this is, just go back to the ward, medicine ward, take 10 anemic patients complete blood pictures, go through their retic count. The guy whose retic count is more than 8%, 7%, 14%, 12% along with anemia, who is that guy whom you are seeing? He is a guy of hemolysis, hemolytic anemia. In him there will be jaundice, in him there will be splenomegaly, etc., etc. Okay, doc? But Buchamma, Ellamma, who is impoverished, suffering from malnourishment, in her what is the cause of anemia? Iron deficiency. In her, if she is not receiving any iron therapy, anemia will be there with a low retic count. Go to that patient Ellaya who has got aplastic anemia. In him also severe anemia will be there, pancytopenia will be there, RBC low, WBC low, platelet count low, and his retic count will be less than 1%. So that is how you make the diagnosis looking at the complete blood picture. Anybody with an anemia with greater than 8%, 7%, 6% retic count means look for hemolysis, is a very important rule. So how do you diagnose? What is the underlying cause of anemia? If the retic count is less than 2, look at the peripheral smear, because it can be due to iron deficiency. Very important index you need to look for is MCV, mean corpuscular volume. If it is less than 80, that means it is microcytic anemia. And what are the various causes of microcytic anemia? 4 causes come to your mind when we say microcytic anemia. 4 causes: iron deficiency, anemia of chronic disease, thalassemias, and ringed sideroblastic anemias. They are the 4 causes of microcytic anemia. In all these cases of microcytic anemia, retic count will be less than 2. Why? If it is iron deficiency, bone marrow want to produce retic count, but iron is missing. If it is anemia of chronic disease, can you give me an example of a chronic disease which can lead to anemia? For example, somebody is having rheumatoid arthritis, somebody is having SLE, somebody is having leprosy, somebody having tuberculosis, osteomyelitis. So many conditions where there is a chronic ongoing inflammation. The inflammatory mediators, which are interleukins, will go and suppress erythropoietin production by the kidney. If there is no erythropoietin, bone marrow cannot be able to produce RBCs. Hence there is a development of anemia. Okay, doc? So anemia of chronic disease, iron deficiency, thalassemia, ringed sideroblastic anemia, these 4 are called microcytic hypochromic anemias. Acha, theek hai. What is the problem in sideroblastic anemia? Fundamentally, In sideroblastic anemia, how is hemoglobin formed? There is a heme and globin chains. Heme is fundamentally a porphyrin. It is formed in multiple stages, protoporphyrin, coproporphyrin, etc. So there is a defective synthesis in the protoporphyrins. If the person is receiving alcohol, if there is a pyridoxine deficiency, or if there is a lead poisoning. And in all these scenarios, the very structure of heme cannot form, and that leads to development of sideroblastic anemia. There is one more important situation where sideroblastic anemia can occur. Normally, iron should get incorporated into protoporphyrin in order to form the heme. The incorporation of the iron into the heme doesn't occur in sideroblastic anemia, and all that non-incorporated iron will get accumulated in the mitochondria, which is responsible for the ringed sideroblasts which are seen in the case of the sideroblastic anemia. Okay, doc? So for now, summarize. 4 microcytic anemias which will come to your mind when you go to the exam hall is iron deficiency, anemia of chronic disease, thalassemia, and ringed sideroblastic anemia. Ringed sideroblastic anemia, 3 causes that comes to your mind are alcohol, pyridoxine, lead. They are the 3 things, and iron deposits in mitochondria. They are the keywords. They are all examples of microcytic anemia. And how do you define microcytic anemia? MCV less than 80 defines the microcytic anemia. Now what you are seeing here is basically called as this is a nucleated RBC in the center which contains the basophilic stippling of the cytoplasm. This kind of stippling can be seen, basophilic stippling, in lead poisoning, which is one of the causes for development of sideroblastic anemia. It can also be seen in cases of even megaloblastic anemia also, is what need to be remembered. Now, if MCV is more than 10 in a patient with a reti count less than 2%, what are the causes? There could be a problem in the nucleus. Fundamentally, any cell is a combination of what, doctor? Nucleus, cytoplasm. Nucleus के अंदर क्या रहेगा? DNA, RNA. Agreed? So, any defect in the formation of the DNA because of the deficiency of the vitamin B12 or folate will typically create what is called as a macrocytic anemia, which is seen in vitamin B12 and folate deficiency, and it will create a megaloblastic appearance. Here you need to understand 2 things. Macrocytic का मतलब mean corpuscular volume more than 90. It can be 95, 100, 110, 120, 125, anything. But macrocytic is different from megaloblastic. Megaloblastic means the nucleus should show the changes histologically. Then only you call megaloblastic. There can be macrocytic megaloblastic, macrocytic non-megaloblastic. Both the things are possible. Liver disease, alcoholism, hypothyroidism, liver disease, alcoholism, hypothyroidism. These are the 3 conditions you need to remember because they also will increase MCV and lead to macrocytic anemia, but it is a non-megaloblastic macrocytic anemia is what I like to underscore to all of you. Favorite question of the examiner. What are the causes of non-megaloblastic macrocytic anemia? Non-megaloblastic macrocytic anemia are liver disease, alcohol, hypothyroidism. That's what need to be remembered. Now in the liver disease, what happens? Why there is a macrocytosis? Liver is very important for the formation of the lipoproteins. Lipoproteins are very important for the formation of the lipid component of the RBC membrane. If the liver is diseased, lipoprotein formation is affected, that will affect the RBC membrane formation, and that lead to development of macrocytosis, is what you need to fundamentally understand. Then any situation where there is a sudden increase in the hematopoiesis, that also will lead to development of macrocytic picture. For example, you have an iron deficiency guy. Agree? Iron deficiency guy will typically show microcytic hypochromic anemia. In him you have started iron therapy. Is his bone marrow intact? Intact. When his bone marrow is intact, when you have replenished iron, immediately what will bone marrow will start doing? It will start proliferating and keep releasing RBCs. When bone marrow is eagerly producing RBCs excessively, then also you will have the development of macrocytosis. Agreed, doc? So what are the three major causes of macrocytosis? Nuclear defect like vitamin B12 folate deficiency, where there can be megaloblastic macrocytic anemia. Then there can be a non-megaloblastic macrocytic anemia in liver disease, hypothyroidism and alcoholism. Third is whenever there is any hyperproliferating bone marrow with an increased erythropoiesis, that also leads to development of macrocytosis, is what I want to underscore to all of you. So this is the story broadly about microcytic, macrocytic. Then comes normocytic anemia, aplastic anemia, any fibrosis of the bone marrow, any tumor. For example, somebody had prostate cancer. That prostate cancer has metastasized to the bone marrow, infiltrated bone marrow, created fibrosis in bone marrow. What is that leading to? What will it lead to? Anemia. What anemia it is called? Myelocytic anemia. Myelocytic anemia. There also you will have normocytic anemia. Any anemia of chronic disease or renal failure where there is no erythropoietin also lead to development of normocytic anemia. So how do you interpret the ready count, doctor? If the ready count is more than 2, possibility 1, there could be a rapid hemolysis, or there may be acute blood loss, like elderly person, he had angiodysplastic lesions in his intestine, colon, which are undergoing bleeding actively, and that is compensated by the bone marrow by radiculocytosis. So that need to be evaluated. Always whenever you have an anemic patient, whether it is an obstetrics ward, whether it is a general medicine ward, first thing you need to do is look for his volume to check whether any hemorrhage is responsible, and look for the hemodynamic instability. If his BP is low, if he is suffering tachycardia, first thing is transfuse the packed RBCs is considered to be the most important part of the management.